Hello everyone and welcome to week 4 of KIN 353, Care and Prevention of Athletic Injuries. This week we'll delve into the thigh, hip, groin, and pelvis. Make sure to read chapter 21 in your textbook. Also, as a reminder, make sure to review feedback that I've given you in your CAP 2, as I've returned most of them back to you. There was a few that were turned in late, and that'll take me maybe through today or tomorrow to finish up. So today I will cover 2 studies in relation to our topic. I think it's important for you to consistently analyze and synthesize current research. It will not all make sense immediately, but the more you take the time to read journal articles, the better you'll get at critiquing the material to utilize the information in your respective fields. In this first study by Cerner and colleagues, they took it upon themselves to better describe groin injuries as they're seen in sports. So the aim of the study, and basically what does the research say about specifically mechanism of injury, clinical findings, and also radiological findings. And this is the reason I want to present the study to you, because there could be times when you can confuse acute injuries such as groin injuries with others such as sports hernias, and hip flexor strains. So the methodology for this study included 110 male athlete participants with an average age of 25 years. And in studies, when you see the word mean, like as in mean age, it refers to the average. And about 70% of the participants in this study were soccer players. Let's take a look at what caused these injuries, so the mechanisms for the injuries of these 110 athletes with acute groin injuries. And just to give you some background, typically groin injuries occur due to a forceful contraction of the hip adductors, which include the adductor longus, the adductor brevis, the pectineus, and the adductor magnus, and the gracilis. So as you can see here, the main culprits of the injuries to the groin here were kicking, change of direction, and stretching situation, which coincides with the etiology that I gave you as far as concentric and eccentric forceful contractions of the groin muscles. Next, the authors found that 66% of the groin injuries occurred specifically to the adductor muscle group, followed by the iliopsoas muscles and the rectus femoris. And as you can see here, this was found whether it was through a clinical assessment or through radiological assessments such as the MRI or the ultrasound. The muscular anatomy can be seen here with the specific groin muscles highlighted, but I also wanted you to see what it looks like on the surface, because when an athlete is describing how an injury occurred, what type of pain they felt, and the location of the pain that they're feeling, it's important to be able to see what the anatomy actually is on the surface, and get a good idea or a good picture of what you're dealing with. The results of the clinical and radiological findings can be seen on this table. Important to note is that the adductor injuries, as noted here, were confirmed radiologically with MRI and ultrasound to the clinical exam. So this was a clinical diagnosis, and then MRI and ultrasound findings. As you can see here, this is the percentage that they correlate with. However, the iliopsoas and the rectus femoris had different diagnoses when taken through MRI and ultrasound compared to clinical diagnosis about a third of the time. So according to the authors, it would be prudent to include the rectus femoris specifically as part of your differential diagnosis when you're evaluating the groin. When an athlete is telling you that it seemed like they pulled a groin, it's also it'd be a good idea to keep in the back of your mind that you want to evaluate the rectus femoris further as well, just to rule that out as an option. Just because In this study and in other studies, they've found that with radiological findings or exams, they do get that as part of the injury as well. And that brings us to the last point of the study, which is to say that um, the authors also found that there was about 1/3 of the time that they were doing all of these exams, they found that there was multiple pathologies or injuries on clinical exams. So not just the adductor or just the rectus femoris. Sometimes a combination of both, which is very true of most injuries to athletes. It's rarely only one structure that, in our, mock orthopedic exams, we're usually looking for one pathology or one injury, but in real life, there's usually more than one anatomical structure involved in an injury. Just like an ankle sprain, it's rarely only the ATFL. It's also usually the talus that could have been bruised, or the lateral malleolus, or one of the peroneal muscles. So just something to keep in mind. The next study discusses femoral acetabular impingement, or FAIs, and how they are treated. FAIs, just to give you some background, are extra bone growths on either the rim of the acetabulum or on the head of the femur, kind of like a bone spur. So Critch and colleagues specifically discuss the effects of cortisone injections on patients with pain from an FAI. And the reason I wanted to discuss this is because you may hear patients, specifically athletes, asking for cortisone injections anytime they have acute injuries which don't fully incapacitate them, but definitely bother them, and they're looking for an option to continue their season, or to maybe play a little bit more comfortably in their respective sports. However, as we'll learn, this is not always a beneficial option, and in fact, it could be a detrimental one, depending on what anatomical structure we're talking about and the number of injections you're dealing with in any given year. So here's the anatomy that we're dealing with as it pertains to the coxofemoral joint, or the hip joint. And as you can see, here's the femoral head, here's the acetabulum, and as you'll see here next, these are the different types of FAIs. We have a cam, a pincer, and also a mixed impingement. So when you read any literature regarding FAIs, you'll understand that a cam impingement refers to impingements that occur to the head of the femur. The pincer impingement refer to impingements that occur at the rim of the acetabulum, and you can also have both, which is a mixed. And here's just a different view of what I'm talking about here. This is the cam impingement, and here's the pincer impingement. When you're reading research regarding any type of treatment, medication, some sort of procedure, you may see the numeric rating scale, which is also referred to as an NRS. And it's just a scale for patients to give, a more objective measure of whatever the scale is being used for. In this case, it's being used for pain. So here's the study in a nutshell. This table here gives us a visual representation of what the patients were experiencing before, immediately after the injection, and then 14 days post the injection. So more specifically, in this study, 54 patients were giving intra-articular corticosteroid injections under ultrasound or fluoroscopic guidance. The patients were given either methylprednisone acetate, triamcinolone, or betamethasone with a local anesthetic. One of those three corticosteroid injections. And as you can see here, because of the anesthesia, or almost all of them had immediate relief. However, once um, after the post injection, you can see the scores go back up, and that's within 14 days of the injection. So it kind of lets us know that it was a short-lived positive experience in these patients with FAI. And going out a little bit further, so 6 weeks post injection, about 3% of the patients reported any significant pain relief. And, for a long term option, it's becoming to look like, a steroid injection probably isn't a very good one. So, just, you know, another note to point out here that the authors highlighted was that intra-articular um, anesthetic injections, or that portion of the steroid injection, does have a use. So these patients, for example, were already surgical candidates. So they were probably going to go into surgery regardless of the outcome of this injection. However, the positive response that they get from the anesthetic portion of the injection is an indicator that whatever is going on at the hip joint is intra-articular, meaning if they still had pain after this injection, the whatever lesion or pathology they were dealing with probably didn't involve structures um, within that joint or in that joint capsule. So physicians could use this as an assessment tool in order to confirm that they're dealing with a chondral pathology, and that once arthroscopic surgery is performed, they're going to find, some sort of intra-articular lesion, such as a labral tear or one of the impingements that were noted before. Lastly, I just want to say that FAIs are typically treated conservatively um, when they're first diagnosed, and they're treated with NSAIDs, or non-steroidal anti-inflammatory drugs, and physical therapy in order to, you know, treat the athlete or the patient within a certain amount of time and give them a chance to, or maybe allow the body a chance to heal. But when patients become frustrated, and, especially if you're dealing with an athlete that has a limited season, they're going to probably push to, get a more aggressive treatment, such as a cortisone injection. But as clinicians, I think you have to be aware of the effectiveness of the treatments that you're maybe recommending for your athletes, such as cortisone injections. Um, and you also must know what the effectiveness of that treatment is, and also what the downside or the detrimental effects of those treatments are. And in this case, as presented by these authors, we see that as far as a long term, as in more than a week or 2 weeks, this is not going to be a very good option for someone dealing with hip pain due to an FAI. So you, as a prudent clinician, want to make sure you have this type of information and know how to utilize it, because you want to be able to tell your athletes with certainty what kind of effects they should expect if they do decide to go through a procedure such as this. So I'm not saying that a cortisone injection doesn't have its purpose. In fact, in certain cases, you can argue that it does serve what it's supposed to do. Maybe your athlete just needs this for one game or 1 week, to finish a playoff event, and regardless of the length of time that it was used for, they were still going to get surgery. So um, it's it's a matter of deciding, is the risk of potentially creating more damage within the hip joint worth the outcomes, them playing in a game or something like that. Um, and as a clinician, you just have to be able to present that type of information to your athlete so they can make an educated decision, and that they're well aware of what they're getting into. So I hope these studies kind of tie in a lot of what is being discussed in the textbook and in the other PowerPoints, and kind of give you a real life situation in which you would use, all of the anatomy and all the different pathologies that you're seeing, and kind of helps you understand how you're supposed to use all of this information. And I do hope it brings up some questions for you guys. Please make sure to ask those questions, email me, or post them in a discussion board. But that's all I have for you guys. Have a great week.